Tissue damage and athletic injuries. Injuries can occur from different events, either large or small. Acute injuries occur from a rapid onset, resulting from a macrotraumatic event, such as the picture on the left of the University of Tennessee football player. As a side note, this football athlete, the one in the orange jersey, has had a very large macrotraumatic event injuring his knee. His entire lower leg is bent the wrong way. This resulted in fractures and dislocations of the knee. This type of injury frequently happens from one incident, and the patient can usually tell you exactly what happened, when it happened, and how it happened. We can also have injuries which occur over much longer periods of time. These are typically referred to as chronic or overuse injuries. Chronic or overuse injuries develop over a period of time from a series of microtraumatic events. Many of us have experienced low back pains, such as the pain exhibited in the picture on the right. Many times you cannot distinguish exactly when it started hurting or what brought it on, but you just know it hurts. Approximately 80% of all people will experience low back pain in their lives. And for the majority of us, eventually, over time, it just resolves on its own. However, that can't be said of all chronic injuries. Time does not necessarily heal all of them. So, which one's worse, an acute injury or a chronic injury? The simple answer is, if you're the one in pain, they can both be terrible. Acute injuries hurt immediately because of a large force or traumatic event. We know exactly what happened, how it happened, and why it happened. Chronic injuries are typically a little less painful, but the pain tends to last for a much longer period of time. They can be very difficult to treat, as it is hard to determine exactly how it happened and why. The way we treat these two types of injuries varies greatly, but it is something we will continue to discuss and explore during this course. How do injuries happen? We start with tissue. This could be a muscle, a tendon, a ligament, a bone, a joint capsule, or any other type of tissue. When forces are applied to the tissue has one of two responses. It can either adapt to the forces that are being applied to it, or it can fail. This is known as Wolff's Law. If the tissue fails from the force that is being applied, then we have a disruption of the tissue, which is how injuries occur. So every time a football player gets hit during a game, why doesn't he get injured? He has muscles, bone, tendon, ligaments, and other tissue, and all of those tissues are being subjected to forces. So why don't they get injured more often? There are several factors that can contribute to the risk of a force resulting in an injury. First is the magnitude of the force. The magnitude of the force has to do with how large the force is that you're being struck with. For example, you might survive being run over by a bicycle a little bit better than being run over by an automobile. The car has much more force potential and therefore could have a greater magnitude of force. In addition, the car can also travel at a greater rate of speed and is also much heavier, which allows it to create a larger magnitude of force than does the bicycle. Second is the moment arm of the force. The further away from the axis point of the human body, this is typically the core, the less force is needed to injure structures. Third, the direction of which the force is applied. Typically, a perpendicular force, or a force that is at a right angle from impact, has the greatest amount of force. If a ball is thrown at you and hits you directly from a 90-degree angle, it actually hurts a lot more than if it glances off of you from a much shallower or much deeper angle. Next is the magnitude of the stress produced. The stress produced by the force depends on the surface area over which the force is spread. For example, a football athlete wearing shoulder pads. When he is hit, the force is distributed over the surface area of the pads. If the athlete was not wearing those pads, the force would be directed over a very small area and could increase the chance of injury. Last, the property of the tissue. Muscle, ligament, tendon, and bone all react differently to forces and stress. Muscle is a lot more elastic than bone, and thus can deform and retain its original shape better. Bone can withstand large amounts of force, but does not have a lot of elasticity, which is great for holding us up, but is really bad when the force exceeds the bone's capacity to withstand it. The mechanism of injury, or MOI, is a common abbreviation you will see within the notes. To understand the mechanism of injury, we need to define different types of forces. First, compression forces are axial loading that produces a squeezing or a crushing effect. The weight of the human body constantly produces compression on the bones that support it. If you think of your spine, the discs are compressed between the vertebrae every time you take a step or even move. Tension is an axial loading in the direction opposite that of compression. Tension is a pulling force that tends to stretch the object to which it's applied. This may feel good to start. Pulling on tissues is a common practice of massage and physical therapy. However, too much tension will disrupt the tissue and can actually result in tissue separation. Tension used to be a form of torture. It was called placing people on the rack. They would place tension on the arms and legs until the joints actually separated, and the soft tissue did eventually too. Eventually, the person was literally pulled apart. Shearing forces act parallel or tangent to the plane passing through an object. When a person stops quickly and the muscles of the quadriceps and hamstrings are not strong enough or do not activate quickly enough, there is enough force for the anterior cruciate ligament, or ACL, to actually be sheared off of the femur by the tibia. This is referred to as a non-contact ACL injury. So if you've ever been watching a sporting event and you see someone and it looks like they're running all by themselves, all of a sudden they fall to the ground and clutch their knee, there's a really good bet that this injury has occurred. Bending are forces that cause one side of an object to come together. Every time you bend over to put on your shoes in the morning, you are creating a bending force in the spine. Now the spine is okay with this bending force, but what would happen if this occurred to a long bone in your forearm? The forearm probably would not like it and would either have to adapt or would fracture. Torsion forces are rotating in opposite direction from each other. The body does not respond very well to torsion forces. When teaching individuals how to lift properly, the technique is always to lift with the legs. Keep the object as close to the body as possible and move the entire body as a unit. Do not twist. Twisting results in those torsion-type forces, and it does not take very much torsion, especially in the spine, to injure body tissues. Combinational or combined forces are any combination of the aforementioned forces. This could be torsion with compression, or a shear with torsion, or any other combination. Combinational forces typically result in very complicated injuries. Our muscles act in much the same fashion as this rubber band. We can stretch our muscles within a certain limit and they will retain their shape, just like this rubber band. But what would happen if we extended our fingers just enough with this rubber band? Eventually, it may break. Our muscles have the same type of property. When this load exceeds what is called the yield point, or the elastic limit of our muscles, they can no longer keep their elastic shape and return to normal. Eventually, the muscle tissue will fail and becomes what is called plastic, which means that it no longer retains its elastic type property and has a permanent deformity. Joints can be classified in different ways, but are describing similar things. Structural classifications of joints focuses on the material binding the joints together. Functionally, joints are classified by how much movement is allowed by the joint. Essentially, the classifications are describing the different features at the same joint type. A fibrous joint is the same as a synarthroidal joint. A cartilaginous joint is the same thing as an amphiarthroidal joint, and a synovial joint is the same thing as a diarthroidal joint. This table might be helpful as a visual representation for the different classifications of joints. Here are some pictures of fibrous or synarthroidal joints. Again, they are held together by fibrous tissue. They are immovable, and some examples might either be the sutures in the cranium or the teeth. Cartilaginous and amphiarthroidal joints are united by a hyaline cartilage or fibrocartilage. They're slightly movable. Synarthroidal and diarthroidal joints. They're most commonly seen as the joints in the limbs. They are freely movable. The next slide has some pictures as examples of synarthroidal or diarthroidal joints. I don't know about you, but pictures paint a better picture for me. In this picture, we have the top left, a hinge joint. We have one concave and one convex surface. It allows for the motion of flexion and extension. This is a picture of an elbow joint. At the top right, we have a pivot joint. This joint is rounded at the end that is rotating within the other bone. This is the picture of the atlantoaxial joint in the spine, C1 and C2. The middle left is a picture of a saddle joint. This is a biaxial joint that is saddle-shaped. This is a picture of the carpometacarpal joint at the thumb. The middle right is a condyloidal joint. It has a concave and a convex surface that move reciprocally. The picture is of a metacarpophalangeal joint of the finger. At the bottom left, we have a ball and socket joint. This is a spherical head and a cup-like socket. This is a picture of the hip joint. And at the bottom right, we have a plane joint or a condyloidal joint. This is two flat surfaces that glide upon each other. This is a picture of the acromioclavicular joint in the shoulder. Synarthroidal or diarthroidal joints have 5 key features. Number 1, they have an articular cartilage. Number 2, they have a synovial cavity. Number 3, they have an articular capsule. Number 4, there is synovial fluid. And number 5, there are reinforcing ligaments. All synovial or diarthroidal joints share these 5 key features. Some may also have articular discs or labrums inside the joint as well. The next section of the lecture is the classification of injuries. We will go through each of these in a little bit more detail, including soft tissue injuries, which includes skin injuries and musculotendinous injuries, joint injuries, bone injuries, and even nerve injuries. The integumentary system comprises the hair, skin, nails, and glands of the skin. It is the largest organ in the body. It provides protection and sensation, and it regulates fluid balance and temperature. It also provides vitamin D and the immune system components. The skin is composed of 3 regions. The outer layer is known as the epidermis. The epidermis has multiple layers containing pigmented melanin, hair, nails, sebaceous glands, and sweat glands. The outer surface is made up of dead epithelial cells, which is replaced every 3 to 4 weeks by new cells that are pushed up from the dermis. The dermis is the middle layer, and it is the largest portion of the skin. It provides full strength and structure for the skin. The dermis contains blood vessels, nerve endings, hair follicles, sebaceous glands, and even sweat glands. The bottom layer is a subcutaneous tissue, which is largely comprised of adipose tissue, which provides cushioning between the skin layers, muscle, and bone. It also helps to regulate body temperature. When examining skin wounds, the acronym APAIL, A-P-A-I-L, is sometimes helpful to determine which type of skin wound has happened. Abrasions are skin scrapes that are due to a shearing force. A puncture occurs when a sharp cylindrical object penetrates the skin. An avulsion is a severe laceration and a complete separation of the skin. An incision is a clean cut, and a laceration is an irregular tear. Blisters are also types of skin injuries. This occurs when different layers of the skin are exposed to friction. Typically fluid, and even sometimes blood, accumulates between the layers of the tissue. A skin bruise is exactly what it sounds like. It is a hematoma that occurs underneath the skin layer. Most of us have had one of these types of bruises, or maybe even a blister, or a cut, a scrape, or a puncture at one point in our life or another. Musculotendinous injuries. These include muscle cramps and spasms, muscle contusions, strains, tendinopathy or tendinitis, tendinosis, or tenosynovitis, and heterotopic ossification, also known as ectopic calcification, and was formerly known as myositis ossificans. Muscle cramps and muscle spasms. Muscle cramps are painful muscle contractions that are due to an electrolyte imbalance and possibly muscle fatigue. They may be the result of dehydration, improper nutrition, or possibly an improper warm-up. There has been some debate recently regarding pickle juice and mustard to treat muscle cramps. Many athletes claim that these are the miracle cure. You can even buy them at Dick's Sporting Goods or Academy. However, the science has not quite caught up yet. There is very little scientific evidence that suggests that the vinegar within the pickle juice and the mustard may prevent muscle cramps. Currently, pickle juice is being marketed in the same way as Gatorade as an electrolyte imbalance solution to help with sports injuries. Muscle spasms are a painful contraction that is caused by a reflex action. When a muscle is exposed to pain and strain or an unexpected force, it spasms as a protective mechanism. With this muscle spasm, it tends to cause more pain, which causes more muscle spasm, creating what is called the pain-spasm cycle. Musculotendinous injuries. These include muscle contusions. These are bruises that occur underneath the skin. The mechanism of the injury is an acute or direct blow. Usually this is from a compressive force. Ecchymosis or bruising is often present and can be very painful, especially to the touch. It forms a hematoma underneath the skin. It is very common to affect large muscle groups like these seen in the pictures. The upper right we have a picture of a biceps which has a hematoma, and the lower right is the quadriceps with a hematoma. We can tell that the lower right picture is a little bit older bruise by the coloring. When the bruise first occurs, they're usually a reddish or purple color. As they start to heal, they turn to a kind of green or yellow coloring. Muscle strains are stretching or tears of the muscle or tendon. It is easy to remember strains because they occur at a tendon. Both the strain and the tendon have a T in them. I hope that helps you. This occurs most commonly at the musculotendinous junction or within the muscle belly itself. A grade 1 occurs when the stretching of the muscle fiber or muscle tears occur. Grade 2 is a partial tear, and a grade 3 is a complete rupture. Within the grading scale for the muscle strain, we can also see associated losses of function, weakness, and pain. With a grade 1 muscle or tendon strain, we can see that most patients are going to experience pain. However, weakness and loss of function does not typically occur. With a grade 2, we have pain and weakness. And a grade 3, the patient is going to complain of pain, weakness, and a loss of function. Tendinopathies are any tendon pathology. The mechanism of injury is insidious, which means we don't have a specific incident that caused the injury, and it typically occurs over a period of time as a chronic injury. There are 3 types of tendinopathies. Tendinitis is an inflammation of the tendon. Tendinosis is degeneration of the tendon itself. This is most likely to happen as a partial or full thickness rupture of the tendon. And then tenosynovitis is an inflammation of the synovial sheath surrounding the tendon. An example of tenosynovitis is de Quervain syndrome. If you grasp your thumb on the inside of your fist and you alternately deviate or point your hand down, you may experience some pain on the radial portion of your wrist. If you do, this potentially could be the start of a tenosynovitis, but it's very common to have tenosynovitises in the hands and the feet. Heterotopic ossification, also known as ectopic calcification, was previously known by myositis ossification. These are formations of a bone within the muscle belly's fascia or within the muscle itself. The mechanism of injury is insidious after an initial trauma and could be from repetitive trauma. These are very common in soccer players and in football players. We can see the X-ray in the upper left. There is a picture of a calcium deposit within the gastrocnemius muscle or the calf muscle right behind the knee. We also have the bottom picture, an X-ray of a myositis ossificans at the distal calf within the Achilles tendon. These are both pictures of soccer players who were unfortunately kicked repeatedly in the back of the calf where there is not any protection from a shin guard. We see this commonly in the quadriceps and the forearms of football players as well. Joint injuries include sprains, dislocations and subluxations, osteoarthritis, and bursitis. A sprain is a stretch or a tear of a ligament and/or the joint capsule. A ligament connects bone to bone. The mechanism of injury for the joint is force beyond its normal anatomical limit. The grading for sprains is very similar to that of strains. The difference between a sprain and a strain is the type of tissue that is involved. Sprains involve ligaments. Strains involve muscles and/or tendons. A grade 1 sprain includes stretching or micro tears of the ligament or capsule. Grade 2 is a partial tear, and grade 3 is a complete rupture. Dislocations and subluxations. Dislocations are complete separations of two adjacent joint structures. The mechanism of injury is typically acute and occurs from passive stretching of the joint beyond its physiological capacity of the capsule and the ligament. In the first-time dislocation, it should be treated as a possible fracture and should never be reduced unless it's being done in an emergency department. As an athletic trainer, we never reduce these first-time dislocations. Now, if somebody has dislocated multiple times, there is a good chance that an athletic trainer can be trained how to reduce a dislocation. One of the most commonly dislocated joints is the shoulder. This happens really commonly in sports when the arm is flexed to 90 degrees and externally rotated, as athletes are commonly in the sports-ready position. The arm gets pulled backwards and eventually the shoulder actually dislocates anteriorly. A subluxation is a partial separation or joint that dislocates and spontaneously reduces itself. The mechanism of injury is acute or chronic. Overloading of the joint in a position of little static or dynamic stability. Your patient is going to complain that their joint feels really unstable. Osteoarthritis is a chronic degeneration and softening of the articular surfaces. The mechanism of injury is insidious and chronic, or may be related to previous trauma. For example, people who have torn their ACL ligament, about 85 to 95% of them will develop osteoarthritis in the knee at some point in their life. Many times, this osteoarthritis becomes bad enough that they actually end up having to have a joint replacement. This most often affects the weight-bearing joints, such as the knee. It is very common also in the wrists and the ankle. Bursitis is an inflammation of the bursa. A bursa is a fluid-filled sac, and it reduces friction between the tendon, muscle, and ligament. It also helps to facilitate smooth motion. The mechanism of injury for bursitis can either be acute from a direct blow or insidious as an overuse injury. Inflammation to a superficial bursa could be dramatic. Here are some pictures of chronic versus acute bursitis. The picture on the left are 4 of the most common bursa located within the knee. We have the suprapatellar bursa, prepatellar bursa, infrapatellar bursa, and the pes anserinus bursa. When people spend long periods of time on their knees, such as tiling a floor or maybe even mopping a floor, they can develop prepatellar bursitis. It is the most common out of the 4. Prepatellar bursitis is also known as housemaid's knee. Most people are unaware that they even have a bursa until it becomes inflamed. We can see in the upper right-hand picture an example of an Achilles tendon bursitis. The left foot is extremely swollen compared to the right foot. In the bottom right-hand picture, we have a bursitis of the elbow. It almost looks in this picture as if there is a structure within the elbow itself. That is the swollen bursa. Again, we would never see this until that bursa becomes inflamed. An inflammation to a superficial can be very dramatic. For bone injuries, we have bone bruises and fractures. Fractures are disruptions of the continuity of the bone. There are different types, open versus closed. There are many different types of fractures, but the most common are simple fractures and compound fractures. A simple fracture is also called a closed fracture. These are where there is no open wound on the skin. The bone has not pierced it. Simple fractures include a green stick fracture, in which the bone is bent but does not completely fracture in much the way a young sapling tree branch bends but does not break. Green stick fractures are very common in young children where the bones are not fully solid. The bone splinters instead of fully fracturing. A transverse fracture is where the bone breaks across at a right angle. An avulsion fracture is when there is a separation of a small fragment of the bone near the attachment of the ligament or a tendon. An oblique fracture is where the fracture happens at an angle and the bone stays at an alignment. Oblique displaced fractures occur when the fracture is at an angle but the bones do not stay in alignment. A comminuted fracture is when the bone has fragmented in multiple pieces. Segmental fractures are when the fracture occurs in two parts of the same bone. A spiral fracture occurs when the bone fracture occurs as a torquing or twisting motion. This type of fracture is common during activities where one extremity is planted and people are spinning around. Compound fractures, also called open fractures. This is when the bone breaks through the surface of the skin, but does not necessarily mean that it will stay there. Some compound fractures may move back into the wound so that it is no longer visible. Epiphyseal injuries or Salter-Harris fractures. Salter-Harris classifies these different types of growth plate or physeal fractures. An epiphyseal injury occurs at a growth plate. This is typically seen in young athletes. Type 1 is straight across and occurs in about 5% of all fractures. Type 2 is above the epiphyseal plate. This means it's above the growth plate. Approximately 75% of all fractures are type 2. Lower or below is type 3. 10% of fractures are type 3 fractures. To or through or transverse is a type 4. Approximately 10% of all fractures are a type 4. Erasure of the growth plate or crush injuries is a type 5. They're very uncommon and less than 5% of all injuries occur as a type 5. The higher the classification, the greater the risk of complication and the worsening of the prognosis. Salter-Harris injuries are very important to growing athletes. If the growth plate fuses prematurely, one bone could end up a lot shorter than another. This may not be quite as big of a deal in the upper extremity, but could be very significant for the lower extremity bones. There may be graphic content on the pictures for the rest of the slides and for the rest of the class. These pictures are not meant to gross anybody out. Rather, they're meant to illustrate the importance of the different types of injuries and the treatments that you could provide. Stress reaction and stress fracture. A stress reaction is an irregular surface to the bone due to altered bone metabolism. If you take your fingers right now and run them down the shaft of your ulna or along the shaft of your tibia, you may notice that there are little indentations and divots along the bone. At some point during your life, you've probably bumped into things and there are stress reactions that have occurred to the bone. A stress fracture is a type of incomplete fracture that is due to repetitive stress. This is common in the lower extremities and is hard to diagnose. Most of the time, patients are complaining of night pain. These are some pictures of examples of stress fractures. X-ray is not very reliable for assessing stress fractures. Unfortunately, stress fractures only show up on X-rays when they're starting to heal. We can see this picture on the foot. A callus has formed, and that's why the X-ray picks up the fracture. Unfortunately, this only showed up approximately 10 weeks after the fracture. We can also see a picture on the left-hand area of a stress fracture to the neck of the femur. This too only showed up approximately 8 weeks after the fracture. We can see better pictures of stress fractures through MRIs or bone scans. Peripheral nerve injuries can have different mechanisms of injury. These can either be acute or overuse. Compression injuries occur, such as the tarsal tunnel syndrome. Stretching, traction, or contusion can happen. Some examples are stingers or burners, which are brachial plexus traction or compression injuries. A transection is a laceration of the nerve. To understand nerve injuries, we need to define different types of sensations. Hypoesthesia is a reduction in sensation. Hyperesthesia is heightened sensation. Paresthesia is a sense of numbness, prickling, or tingling. Neuralgia is a chronic pain along a nerve's course. This could be due to irritation or damage of the nerve. A neuroma is a mass formed around the nerve. We can see in the picture, number 1 labeled in the picture is a swollen digital nerve. Number 2 is the Morton's neuroma. This is a growth or benign tumor of nerve tissue. Number 3 are branches of the digital nerve. So what are the clinical features of a neuroma? Normally there are no outward signs such as a lump. Nerve pain includes a burning pain, sometimes into the ball of the foot, and can radiate into the toes. The pain generally intensifies with activity or with wearing shoes, but night pain is rare. There is also numbness, sometimes in the toes, or an unpleasant feeling. Runners may feel pain as they push off from the starting block. Also, those who wear high-heeled shoes. It puts the foot in a similar position to push off and can aggravate the condition. Tight, narrow shoes can also aggravate this condition by compressing on the toe bones and pinching the nerves. Unfortunately, to deal with this type of neuroma, most of the time surgical intervention is the correct option. We're going to switch gears a little bit and talk about wound care following an injury. The phases of tissue repair often overlap each other and can be hard to understand. The first phase is bleeding. It begins at the onset of injury, and the objective is to stop the bleeding. In this phase, the body activates its emergency repair system, the blood clotting system, and forms a dam to block the drainage. During this process, platelets come into contact with collagen, resulting in activation and aggregation. An enzyme called thrombin initiates the formation of a fibrin mesh, which strengthens the platelet clumps into a stable clot. Phase 2 is a defensive or inflammatory phase. This focuses on destroying bacteria and removing debris, essentially preparing the wound for growth of new tissue. During phase 2, a type of white blood cell called a neutrophil enters the wound to destroy bacteria and remove debris. These cells often reach their peak population between 24 and 48 hours after injury, reducing greatly in number after day 3. As the white blood cells leave, specialized cells called macrophages come in to continue clearing debris. These cells also secrete growth factors and proteins which attract immune system cells to the wound to facilitate tissue repair. This phase often lasts 4 to 6 days, and it is often associated with edema, arrhythmia or reddening of the skin, heat, and pain. Phase 3, or the proliferative phase. Once the wound is cleaned out, the wound enters phase 3, where the focus is to fill and cover the wound. The proliferative phase features 3 distinct stages. 1. Filling the wound. 2. Contraction of the wound margins. 3. Covering the wound or epithelialization. During the first stage, shiny, deep, red, granulated tissue fills the wound bed with connective tissue and new blood cells are formed. During contraction, the wound margin contracts and pulls towards the center of the wound. And at the third stage, the epithelial cells arise from the wound bed or margins and begin to migrate across the wound bed in a leapfrog fashion until the wound is covered with epithelium. The proliferation phase lasts anywhere from 4 to 24 days. Phase 4, the maturation phase. During the maturation phase, the new tissue slowly gains strength and flexibility. Here, collagen fibers reorganize, the tissue remodels and matures, and there is an overall increase in tensile strength, although maximum strength is limited to about 80% of pre-injury strength. The maturation phase varies greatly from wound to wound, often lasting anywhere from 21 days to 2 years. The healing phase and process is remarkable and complex. It is also susceptible to interruptions due to local and systemic factors, including moisture, infection, local maceration and age, the nutritional status of the body, as well as other environmental factors. The inflammatory phase are days 0 through 6. The most common symptoms we see are redness or arrhythmia, local heat, swelling or edema, pain, and loss of function. During the inflammatory phase, we see an immediate vasoconstriction up to about 10 minutes. We also see a platelet reaction, which forms a platelet plug or clot. We see a clotting factor and formation of the fibrin clot, and then vasodilation. Acute inflammation is a rapid response to an injurious agent that serves to deliver mediators of host defense, leukocytes, and plasma proteins to the site of injury. Acute inflammation has 3 major components. Number 1, alterations in vascular caliber that lead to an increase in blood flow. 2, structural changes in the microvasculature that permits plasma proteins and leukocytes to leave the circulation. And 3, immigration of the leukocytes from the microcirculation. Their accumulation is at the focus of the injury, and they are activated to eliminate the offending agent. Acute inflammatory reaction can be triggered by a variety of stimuli, anything from infections, trauma, physical and chemical agents, tissue necrosis, foreign bodies, and immune reactions. The proliferation phase occurs from days 3 to 21. During this phase, development of new blood vessels, or angiogenesis, occurs. Fibrous tissue growth, or fibroplasia, also occurs, and the generation of new epithelial cells, or re-epithelialization, occurs. The maturation phase can last from a month to a few years. We see a decrease in fibroblastic activity, a return to normal histochemical activity, and remodeling of the tissue along the lines of the tensile force. We may also see the formation of scar tissue. Depending on how the collagen fibers are laid down, the scar may be very noticeable or very minor, depending on the size, length, shape, and location of the wound. To decrease the appearance of scars, keep them out of sunlight or rub sunscreen on them when you're out and about. Scar tissue is very tender, much like a baby's skin, and can get easily sunburned. It will create a darker pigmentation to protect the new tissue from the sun. Bone healing is a little bit different and occurs in 3 phases. The acute inflammation lasts for approximately 4 days. During this phase, a hematoma forms, vasodilation and edema occur, and in the next phase, repair and regeneration. Osteoclasts reabsorb the damaged bone tissue. Osteoblasts build new bone tissue, and a callus forms. During maturation, some shape changes to the overall structure and integrity of the bone change forever.